GLP-1 agonists are everywhere. But are they really all they're cracked up to be? Or is the ground going to open up beneath these blockbuster medications? Let's find out. Now, this is part 2 of 2, so if you missed part 1, make sure you listen to that first. We're here with Dr. Sean Wharton, who has his doctorate in pharmacy and medicine from the University of Toronto in Canada. He practices internal medicine and is the director of the Wharton Medical Clinic, a community-based weight management and diabetes clinic. He's an adjunct professor at the University of Toronto and adjunct professor at McMaster and York University. He's the lead author of the 2020 Canadian Obesity Guidelines, which has been recognized around the world. And he's also published many peer-reviewed articles in international medical journals, including lead author on several New England Journal of Medicine articles. Dr. Wharton is also involved in advocacy to achieve health equity in medicine. Again, this is part 2 of 2, so if you missed part 1, check that out first. But first, a word from our sponsors. You're listening to Succeed in Medicine, the show for practicing physicians who want to master the parts of their career and life that med school never prepared us for. From interpersonal skills to career navigation to the essential information every physician needs. I'm Dr. Bradley Block, and in every episode, we bring you brass tacks advice and immediately applicable insights from world-class experts, so you can feel prepared wherever your MD takes you and build a life in medicine that's sustainable, rewarding, and actually worth all those years of sacrifice. Dr. Sean Wharton, thank you so much for being on the podcast.
Absolutely, Brad. It's really good to be here. It's a great podcast.
Thank you. The high prevalence of substance use disorder in ADHD. And so when you put them on a stimulant medication, it decreases their likelihood of developing a substance use disorder. You are not giving them a drug that makes them more likely to use drugs later. You're treating their condition, which makes it less likely for them to develop a condition that stems from the underlying condition. And so, you know, what you're saying about the GLP agonists, that they're not going to create an eating disorder, because that's a completely different disorder, right? That's a mental health condition, unless it's that their obesity ends up leading to mental health disorders that would send them down that path. So in fact, by treating it, you are making them less likely to develop all conditions that stem from that.
Where did you come from, Bradley Block? I've been completely serious here. This is the new line of treatment that we're actually looking at, because the clarity needs to be is that somebody with binge eating disorder, mental health disorder, or who has bulimia and an eating disorder, but happens to have a BMI of 32, yet they have bulimia. They're vomiting and they're doing all things. Guess what they need? A GLP-1 analog to get them into ordered eating. It reprograms their brain so they can have ordered eating, and they're living with excess adiposity. If they have a BMI of 18, and they have to believe me, that's going to be a challenge to actually give that. But what we're learning is that eating disorders may be able to be nicely treated with this medication, because the medication works in the brain like an antidepressant or a mood stabilizer, or just it stabilizes that scattered intensity that is happening and calms it down and lets them have breakfast and lunch and dinner, and in an orderly fashion, because they're looking for order, they're looking for clarity, and that helps their mental health disorder and gets them out of it. So I've treated people with eating disorders with GLP-1s, and their eating disorder gets tremendously better. They still need a CBT and some psychological profiling.
But it's an adjunct treatment. And does it also work for substance use disorders? Because I've heard that alcohol, people seem less inclined to drink when they're taking it.
Yes. So the possibility is that they likely do. And the studies have been perfectly clear, but there's some studies that are showing, yes, it does treat it, and some studies that are just stable, that it didn't make it worse any better, it was just kind of quiet. So in general, if it is quieting the brain or making the brain more orderly in an addictive world, then we can see why this could be a reasonable treatment. The issue with some of these disorders is there's so many other drivers, the people that they hung out with. Like when it comes to heroin and some of the other and alcohol, like being at the bar 2 o'clock in the morning, the food eating and the obesity, that can be quelled a little bit more because you have more people that are wanting to help you and wanting to be part of the picture and the weight coming down, etc. But with this other stuff, they really miss that environment. But it does end up, so there's so many other factors, but this likely will be a nice way to help them to move in the right direction along with their CBT And there are other treatment options.
Great. Oh, so we're finding out so many wonderful things about these medications. But I want to get back to what we were talking about earlier, which is the difference between the medications, right? So there's a bunch that are out there, and without sounding too much like just rattling off a list, right? But if we could quickly go through which ones are which and how they're different.
Yeah. And people say there's a lot out there, but there isn't. There actually isn't. There's only really two. So that's all you have to really remember. You have to remember semaglutide, which was that unicorn, beautiful molecule that Novo came up with in the 2000s. And at 2.4 milligrams, it is called Wegovy. And at 1.0, it's called Ozempic. Now, if somebody has just a little bit of obesity, maybe they can do well on the 1 milligram dose. They're not that severe. Maybe they need the 2.4 all the way up. So that is the Wegovy product. And then there's the tirzepatide, Eli Lilly. And they came up with the dual agonist. So the first one, the semaglutide, is a monoagonist, just has one GLP-1 that sticks in. And then the tirzepatide is a dual agonist, it has GLP-1 plus something called a GIP. It's another glucagon-looking like hormone that we don't know what it does. We literally don't know what it does. I think of it as American football. You have a running back that's pretty darn good and gets into the end zone often. That's semaglutide. Pretty good running back. And now if you have a running back and a blocker, so that GIP is the blocker, that running backs can get into the end zone a lot more. And there's a new molecule that they just announced the top line results. It has two blockers. So it's a triple agonist. GLP-1 is in the middle, and then two other blockers that GLP-1 gets into the end zone. And the weight loss was like 30%. But this is still top line based. It's not available. When we're talking available, it's two molecules, semaglutide 2.4 milligrams and tirzepatide at 5, 10, and 15 milligrams, which is called either Mounjaro or Zepbound.
Okay. Mounjaro is at the higher dose and Zepbound is or vice versa.
It's a funny thing. Mounjaro and Zepbound are the exact same doses, 5, 10, and 15. So why in heaven's name would anybody have two names for it? Because the FDA and maybe Eli Lilly decided that's what was needed, because maybe there was bias against obesity. So we're going to use this Zepbound molecule, which is not going to be covered. And it's for people with obesity. And we're not going to pay for it and make them pay for themselves. Call it a different name. So there's other countries like in the Middle East and a bunch of other places that said, no, we're not going to do that's stupid. It's one drug. It's one drug, all the same dose. It's going to be one name.
Well, that's fitting. There's a lot of stuff that we do here in America that is stupid. Yes.
We're not going there. So a bunch of countries in Europe, Middle East, around the world call it Mounjaro. That's it. There's no Zepbound. So this is an American phenomenon, and it's kind of infiltrated a little bit in the countries that touch America. So Canada, we have it as well. It's the two different names. There was a debate as to whether we were going to let that happen because it's nonsense. Right? It just doesn't make any sense. And the Ozempic and the Wegovy, at least they're two different doses. So you can almost see the reason for it. But even that's stupid. It's just what we go, Ozempic at one dose and Ozempic at another dose. They're the same thing. So it's frustrating. And that's why people get confused because of the insurance plans. The insurance plans and et cetera. So there are only two drugs right now that you can write a prescription for and a person can actually go on to. And in the future, there's going to be 10 or 20, but right now it's two.
So you had mentioned before that part of the reason it needs to be injected is just because it's such a large molecule, but they're coming out with an oral version. So how are they getting around that challenge?
Yeah. So there's two oral versions that will likely be on the market in 2026. The one oral version is that exact semaglutide molecule, that big peptide. But as I said, it's not as big as insulin. What they were able to do is they found a genius company that made this thing called a snack, SNAC. Stands for some long chemical name. But they surround that molecule.
Obesity, and you're naming this a snack?
This is the first time I've ever thought about that. Can you believe it? I'd never thought about that. That is, because I just live in this world. I don't even think we call it a snack. Yep, it's called a snack, SNAC, which stands for some chemical name, as I said. And that what that does, it surrounds that peptide and decreases the pH in the gut. So locally, right around the molecule, the pH changes to allow that molecule to stay intact a little bit, to get across the gut barrier into the bloodstream, and 1% gets into the bloodstream. So you take a 25 milligram pill and you get 0.25 milligrams in. So the question is that 1% bioavailability, that fancy word, of course, is it going to make a difference? Because I'm a pharmacist. I do my doctorate in pharmacy. So I love kinetics, which is the way the drug moves and gets into the bloodstream. But the pharmacodynamics is what the drug does, what the effect is. So the kinetics, great, important, area under the curve, how much gets into the bloodstream. But the really important thing is, did they stop their food noise and lose a bunch of weight? And the answer is yes. They lost as much weight as the injectable.
See, I would think that would be like, if it's only 1% that ends up being bioavailable because the rest of it just gets metabolized or degraded before it gets, I would think that the variability would be significant, that sometimes it's 98% that gets degraded. And then now you've got twice as much medication in you. And sometimes it's 98, but now you've got half as much medication because you're relying on this to your digestion to be consistent every time. And is that, we're getting a little off topic.
But no, but that's brilliant. That's really good. And I think that's why this is a nice drug. Like I said, the semaglutide molecule, I love it. It's a beautiful molecule. But this idea of the oral may be a little bit challenging because of what you just said. It's hard to take. You have to take it in the morning, separated from all other food and medication by 30 minutes. And you have to take it with 4 ounces of water, not 3, not 5, 4 ounces.
So then we're relying on the patients to do exactly what they're supposed to do. And that's hard because they have complicated lives.
That's hard. Because they're human beings that have complicated lives. In the clinical trials, they were motivated. They did an excellent job. In the real world, will they be motivated? Maybe. You know what? I think a number of people probably will be. This probably fits for some people. If you're on thyroid meds, no. Because you take thyroid meds without any food in the morning, and it's going to be hard because it's got to separate it from the thyroid med and separate it from, so that's going to be difficult. So you can see there's difficulty here, but it was nice science. It was very pretty science. And the fact that we got the weight change, there's so much variability in weight change period that maybe it doesn't really matter all that much that it goes from 1 to 1.5% or 2%, that it's just, so it's still within their zone of the weight loss that the person needs. So that is molecule number 1, going to be available in 2026. Molecule number 2 is, as I said, Dan Drucker isolated the receptor. We put a big molecule inside that looks like our own GLP-1. The question is, can you put a small chemical inside that actually works? Most of the time we put a small chemical inside a receptor and it doesn't work. Nothing happens on the bottom. Here, a small chemical and it worked, called orforglipron. So it's a chemical molecule with ammonia. It's not based on peptide ammonia. So you can make it chemically in a lab, make 1 million of them in half an hour, no problems. And which means you can ship it all around the world. You can store it easily. You can take it once a day without worry about food or water or timing or anything else like that. And it worked. And it got to not as much weight loss as the injectable, pretty darn good weight loss. So we talked about this fear doctors have with injectable molecules, and patients don't have the fear, by the way. They don't care about the injections. Doctors have the fear of giving an injection and managing it and titrating it. But that fear will be overcome by these potentially oral molecules, particularly this easy to give, no problem, not huge weight loss. It's not 25, 30%, 12 to 15. It's nice, safe. No issues, no problems.
That's going to be a larger
I think it's going to be huge.
Right? Because if you think as you get higher and higher into BMI, it's a smaller and smaller percent of the population that has that. With any disease process, right? Like the percent of people that have severe asthma as opposed to the percent of people that have mild asthma, like a lot more. A lot more people have mild migraines infrequently than frequent migraines. So the disease process, you just get less. So it really makes sense that that would be a large percent of the population that would be appropriate for.
A very large percent of the population. So in this trial, which I'm the lead author of both of the oral trials, both oral semaglutide in that nice little snack molecule, which I love the science and the technology behind it. And I love the small molecule orforglipron. In that trial, we actually enrolled a lot of people with lower BMIs. When there's a bunch of my other trials that we've done, it's always high BMIs, 35, 40, 45. This one, there was a ton of people with a BMI between 27 and 30 with prediabetes, with hypertension, and that real disease and real weight. But these people were never looked at in previous trials because they were like thrown to the side. Meanwhile, there's a bazillion of them out there in the world that are ready to get the benefit of these medications, and we overlooked them. It's time to look at them and let them have medication to stop the food noise, to get their disease under control. Who wants diabetes? I don't have pre-diabetes. I can take a medication that helps me be a better person, go to the gym, and helps me eat better, and helps me eat healthy foods. I'm taking it.
If you like this podcast episode, you're going to love the other shows over at the Doctor Podcast Network. For instance, The Scalpel and Sword, hosted by Dr. Lee Nagendran Sharma, a previous guest on this show, who discussed conflict resolution. Covers topics like industrial psychology and personal development, ethics, and you guessed it, conflict resolution in healthcare. Check out Scalpel and Sword. Amazing. A lot to look forward to here for a lot of our patients that have struggled for so long. We've been talking about all the positives, though, but I want to get into a little bit of the side effects. What are the things that we need to look out for? What are the things that we need to warn our patients about, right? There have been some, and it's whenever there's a problem, it ends up in the news. So I want you to help us separate what is a genuine side effect from the sensational news out there.
Yeah. So somebody said that if your drug doesn't have a side effect, then it's not a drug. So we know it's going to have something. So what do these guys have? These guys have mainly GI side effects. So it slows the actual gastric motility. So we're getting things like, so that's at the gut level. And then maybe that interacts with the vagus nerve to the brain to cause the nausea and sometimes vomiting and sometimes burping and belching and cause constipation and also diarrhea. Both can go both ways, diarrhea or constipation. So those are the interesting thing about those, except for the constipation, all the rest of them, the nausea, the vomiting, and the diarrhea all get better over time. It's like by taking it to starting low and going slow, just like thyroid meds, just like fiber. Somebody says, hey, so you got to start taking fiber for your bowels. If you take a whole bunch of fiber on day one, you may not go so well. So you start low and you go slow, but you keep going and keep titrating up to the effect, and then things get better and better. So that's the same thing here. The majority of people will end up doing perfectly fine. There's some people who actually won't, and those are the ones that we end up hearing about at times, and they just can't do it.
And they
but
stop the medication, and then everything returns to normal?
Yes. Stop the medication, everything ends up going back to normal. There were some reports, but those were anecdotal and not substantiated that things didn't go back to normal. But that is not the case. Millions of people are taking this medication. You stop it, it goes back. And sometimes people try it again. They're like, okay, stopped. I got rid of that, back to normal. Let me try again, slower this time. And the baby doses, little smidgen doses, because I really want the effect from this drug that's going to help me. And so that's not been proven. There's some now evidence and work that it may make it better. That it may make a lot of these vision things better. So what we definitely know is in type 2 diabetes, if you drop your sugars very fast, you're going to have problems with your retinal vessels. And then you end up getting blurry vision and a number of other things. And so the patients who don't have type 2 diabetes and are getting that blurry vision issues, that's where it is more of a, is this real? Is it not real? At the current time, we don't have any solid evidence that there is even a pathological basis for it. A lot of the reports came out of ophthalmology clinics and such who have everyone's on these drugs nowadays.
When the COVID vaccine came out and you have a boatload of people all taking the same thing at the same time, what I told my patients is crazy things happen to people every day. And when you give everyone the same thing at the same time, those crazy things are going to seem like cause and effect. It's going to seem like it did this thing and then this happened and therefore it caused it. And really it's just this, statistical noise. And so that's what you're saying. If anything, it might treat the underlying condition better, right? You're trying to treat the diabetic retinopathy. Okay. So are there any other myths out there that you want to, because we are rapidly running out of time. And so I want to make sure that we do our job as mythbusters here. Anything else, misinformation that's out there that you'd like to clear up about this class of medicines?
Yeah. And the interesting thing is like a lot of the myths get cleared up just over time. The Ozempic face and Ozempic butt, we don't hear about that anymore. That was last year. Because, you lose a bunch of weight in your face, goes like this. It would go like that with bariatric surgery, or you going on an extreme diet. That's your face. I'm sorry. It's not Ozempic has anything to do with
weight loss face. Yes.
The weight loss face. Exactly. And a lot of these things are getting cleared up. So it's the fear and the bias that has pushed all these things. So something else is going to come up and something else. So in terms of the myths, I think that one of the careful things we should do is don't be so ardent about you have to take this forever. And what I mean by that is, of course, the science and the biology says exactly that.
But you don't need to say it. You don't need to be so, it's in the delivery. So let's try this. Let's see
right, it's
how
in the
you
delivery.
do on it. Do I need to be on it forever? Let's see. Let's find out together. Yeah.
Together. It's almost being cruel to be so like in their face with the delivery of such a scientific principle. When in fact, people are living in a world of bias and stigma and information that they got from The Biggest Loser and Jillian Michaels and all this stuff. It's all filled in their head. It's challenging for them to get rid of it all of a sudden. Give them a chance. Give them an opportunity. Don't deliver the message in such an exact way. If they say, how long do I have to be on? And say, I don't know. As long as we need to be. As long as we can work together. If you want to come off, you can come off and we'll try to do it together. I can't tell you that you can stay off. I'll tell you that I can be here with you. I can show compassion and there's ways of doing this. So let's do the best we can.
Yeah, that's an excellent point because I think a lot of people are reluctant to start it because they feel like if they do start it, then they'll need to be on it indefinitely. And I think the softer approach is going to be much more of a service to your patients.
Because if people drive themselves to lose 25% and think they're going to keep it off wonderfully, then maybe they shouldn't have done that. So they're now driving that boat into the wrong direction. But I think if you're going with somebody who's going to that kind of weight loss, you know that there's someone who's going to stay on it. You've talked to them, you've worked with them, but somebody who wants to go on and off it, maybe titrate them to like 10% change. And then maybe some of them may be able to keep it off because they learned some behaviors, they learned some CBT, they learned how to do certain things. Give it a shot, but keep on working with them, which is why I think these pill forms that are going to have that 10 to 15% weight change and 12% on average are going to work out very well because they're a softer approach, a more appropriate approach, and people who need more and are going to show you evidence that they either understand the physiology or are going to work with you or et cetera. You can ramp up.
Amazing. If our listeners want to learn more about you, they want to learn more from you, how do they find you online?
Oh, that's what. So yeah, I'm on LinkedIn at DRSCAN Wharton, WHARTON, like the Wharton School of Business. That's spelled the same way. So that's how you spell my last name. And I have an Instagram. It's at DRSCAN Wharton. And I have a couple videos on there, some positive things that have happened in the field.
Well, thank you so much for all of your contributions to medicine, for giving us your time today and your knowledge and all you do for your patients.
Thank you very much, Bradley. I really appreciate it. It was fun.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means either you fell asleep or you really liked the episode. So please write us a 5-star review, take a screenshot, and email it to me so I can send you a quick guide on how to earn patient trust in 20 seconds or less. Email me at brad@physiciansguidetodoctoring.com and feel free to suggest a topic or guest. I take your requests seriously. The views expressed on this episode are those of the interviewer and the interviewee and do not represent the views of their employer or even their significant other. Even though the magic of podcasting makes it sound like I'm talking directly to you, this is not a doctor-patient relationship, and this is not medical advice or financial advice or legal advice or really any advice. Thanks again for listening to Succeed in Medicine.